Hey, good morning, guys. Today we're going to cover chapter 31, cognitive disorders. Okay, and let's begin. What is affected in cognitive disorders? Well, you have a dysfunction in the individual has a dysfunction in the mental capacity, okay, in cognition. And what is cognition? That ability to think and to perceive things in the environment. So they can't think things through, and they really have uh, a problem with perception, perception and orientation, and orienting themselves to where they're at, and they forget where they're at. They have a problem with calculating. They can't really work with numbers, calculate numbers. Memory is also affected. You have short-term and then either long-term memory with cognitive disorders. You have problems in vocabulary. Sometimes they can't form the words that they want to speak. And there is also attention. They have problems with attention, staying focused, and abstract thinking. Okay, so when we look at these areas and you have a disruption in these areas, then what we're talking about is a cognitive disorder. Okay, next slide. We'll go to 3. So, categories of cognitive disorders, we have delirium and dementia. What is delirium now? So delirium is an acute disruption in the homeostasis of the brain. Okay, so it's acute, meaning it's not going to last long. So generally, when you resolve the problem of what caused the delirium, then you resolve the disorder. Okay, so it's simple as that. It's reversible. Okay, unlike dementia is a pathologic disorder which is irreversible. It's progressive and it's chronic. It's chronically progressive. It just keeps getting worse, dementia. But delirium is reversible. Okay, so again, the homeostasis of the brain, that stability of the brain is disrupted for some reason or other. Okay, so what can we let's move on. And delirium, factors that affect it: aging. As you get older, you might have more risk of having a delirium. Postoperative status. Okay, so if you've had some sort of surgery, hip surgery, heart surgery, then you have a tendency, or you're at risk for delirium. Metabolic disorder, if you get into sepsis, you have a really bad infection, kidney infection, bladder infection, cardiovascular surgery, drug withdrawal can also do it, and any toxicities from exogenous substances, anything that's affecting you from the outside. Okay, drugs, anything affecting you. Okay, also taking multiple medications. Sometimes the elderly have to take a lot of medications, and that can also put you at risk for delirium. So, categories of disturbances: delirium. Okay, so where can we see these disturbances at? Basically, when can you see it? Okay, when you've have had head injury, a contusion, hemorrhage in the brain, and a tumor. Okay, so in the brain, basically, you're gonna see any disruption in the homeostasis of the brain is going to cause it. Any toxic substance affecting the brain. Okay, anything that affects the brain at that time. Okay, response of the brain to systemic disturbances, systemic, something in the system, like we mentioned before, a metabolic or cardiovascular disturbance. When we say metabolic, what are we talking about? Well, maybe an electrolyte imbalance, an infective process. We also, it can happen when we have uh, diabetes, like going to diabetic coma, cancer, hypoxia from not enough oxygen, maybe too much carbon dioxide, and we mentioned sodium, which is part of the electrolytes, and infections, and then fever and uremia. Okay, all these systemic problems can lead to delirium. Okay, also I'd like to mention exogenous substances like drugs, anticholinergics, antidepressants, narcotics, corticosteroids, and neuroleptics can also cause delirium. And again, we let me just mention that an individual going through withdrawals also from alcohol or substances, barbiturates, tranquilizers, anything like that, sedatives, they can also have delirium. Now, we definitely want to mention again that delirium is reversible. So once you've taken care of this problem, whatever it is, the hypoxia, the head injury, etc., then you will see a reversal of the symptoms, and things will be better off for the patient. They'll get better. Let's look at the prevalence of delirium. Delirium is the most common psychiatric symptom in general hospitals, and it occurs up to 50% of elderly patients. Okay, that's a key. That's part of the answer in question on slide 8. And the incidence of delirium, 30 to 40% of clients over 65 years old experience delirium while in the hospital. Okay, and 10 to 15% on admission. And for patients 75 years or older, 65% of them experience delirium in the nursing homes. So those of you who have worked in nursing homes can attest to this, that you have seen patients with delirium, and sometimes it could be difficult to treat them. More than 80% of clients with terminal illness, and 30% of clients in the ICU, and 40 to 50% of clients recovering from hip surgery, 50% from post-cardiotomy clients also experience delirium. This is ICU. It's called ICU psychosis because of being in the ICU with you get these individuals sometimes get disoriented. They're on a lot of medications, and they're in a locked room wherever that ICU is, and pretty much they can experience delirium. Okay. Alzheimer's disease occurs in 10% of people 65 years old or over. Okay, and 85% 85 years and older experience 50% of them experience delirium. Okay, diagnostic criteria of delirium. Okay, so how do we diagnose it? Well, we're going to see cognition, of course. You're going to have difficulty processing thought and perception, the way that they perceive things. So they're going to be disoriented, and they're not going to be able to really reason with you. It's going to be difficult talking to these patients because they can't really process what you're saying. Okay, And we're going to see also orientation problems. In orientation, they're going to be it's oriented to time, place, person. They may not know who you are. They may not know where they're at and what day it is, etc. And they may have a cloudy sensorium, kind of cloudiness in their head. Attention, we mentioned before, they're not going to be able to focus on any one thing. They may have sleep disturbances. Day-night reversal means that they sleep in the day and they're up at night. They could also experience nightmares. And they may have some psychomotor agitation. They may be hyperactive and running around like, oh my God, oh my God, and unpredictable. Or they could be sluggish, slow, etc. And they can also express pressured speech, rambling speech, like pressured, like, and then ramble on. I don't know what's going on, and then very, very disorganized in a sense. The emotional status of these patients can be very labile. They could be 1 minute, they could be dysphoric and kind of weeping, crying, and then all of a sudden then they start moving out of dysphoria, and then they start getting a little more elated and euphoric, and now they're happy. And then they can also be yelling, or they could be depressed and angry with angry outbursts. So it's really it fluctuates. A lot of their symptoms will fluctuate. But remember again, delirium, reversible. The goals for clients with delirium, you want to definitely decrease the risk factors, and especially when we're dealing with safety. So you want to keep this person safe because they're disorganized, they're not really processing thought well, they're not able to judge things correctly, so the judgment is off, and they may be impulsive because of the impulsivity that is generated from the disorder. Okay, they may need help taking care of themselves. They're not going to be able to process what they need to do, how they need to perform executive functionings, either or ADLs. Okay, and meet their own basic needs. Okay, and definitely orient them. Now let's look at dementia. As we mentioned before, delirium is reversible, but unfortunately, dementia is irreversible. So basically, we see the same symptoms. These symptoms where you have the perception, cognition, perception, thinking, the way they can't process thought. Things don't seem understandable to them, when you're talking or explaining something, and or their orientation will be off, person, place, thing. Okay, and you have memory. They won't be able to remember things. So same with dementia, you'll see that also. And then you'll have vocabulary problems, forming words, etc. And attention will be sporadic. They can't focus on anything, and definitely they can't abstract, and no parables. They can't decipher any parables. So you'll see that. Okay, so this can happen from a medical condition, dementia. I'm speaking of dementia, yes, and or multiple biologic causes, something biologically, physically that affects them, their thinking. Okay, although you have many forms of dementia, basically dementia affects memory and the way that a person thinks. So we'll see with dementia multiple cognitive deficits, and we're going to talk about them, and impairment in social and occupational functioning, and a decline basically in the previous functioning of that individual. We're going to look at a patient with, we're going to look at aphasia, is a hallmark finding with dementia. And what is aphasia? That's difficulty forming new words, forming words. And it's believed that the area of the brain called the Wernicke's area is affected, and that's why these people, patients, people, have difficulty forming words. That area of the brain is affected. Okay. Deficits related to dementia, and again we mentioned memory is affected, so you have impaired learning, short and long term. Usually it's short, and then short-term memory, and they can remember long-term, but then after a while both are affected. Okay. Compromised ability for complex tasks. Okay, difficulties with executive functioning, like meal planning and organizing themselves, managing the checkbook, driving. These patients definitely cannot drive a car. Agraphia, which is difficulty writing, okay? And impaired reasoning. They're not able to respond to everyday problems. Impaired reasoning, they can't reason things through and think them through. For example, if they flood the bathroom, let's say they leave the water on and the bathroom is now flooded and there's water everywhere, they'll get to the bathroom, they'll see it, and they will have a meltdown. They might start crying and they don't know what to do, and it doesn't dawn on them that all they have to do is shut the water off and get the mop and mop it up, and they will just not remember that. Okay. Let's see what else we have. Oh, okay. All right. So we were talking about deficits related to dementia. Compromised orientation and spatial ability. Okay, so now here we go. They're not able to really determine through sensory input, kind of like grab the information and say, okay, I need to do this, this, and this. No, they are not going to be able to do that. Concentration is going to go down, and they're going to easily be distracted. Okay, and also agnosia is a key term that you need to remember. This is the inability to recognize objects like the telephone. They may not recognize the phone, and if they do, sometimes they know it's a telephone, but they don't know how to use it. Even though they've been using it for years and years, they just forget how to use the telephone. The remote control for the TV, they may look at it and not know what to do. Okay, then we have a language deficit, aphasia, another key term you need to remember. It's difficulty following conversation and forming words that they need to express. They may know what they want to say, but they get frustrated because they can't find the words. Okay, and then we'll have also behavioral problems, where you'll see there is sundowning. The patient will sundown means that around 6-7 o'clock they'll start getting very agitated. They'll start walking around and in a meaningless manner, wandering, and they won't know why. So the soundness of the brain gets worse during the night for these patients. Then we have apraxia, another term you need to remember. And apraxia is the ability to carry out certain functions, like motor tasks, like brushing your teeth. So if they can't remember what the phone is, right? They don't remember the phone, and they also forget how to work the phone, is apraxia. So they can't recognize the phone, agnosia, and they forget how to use it, apraxia. So carrying out motor functions is also a key component of dementia. So let's look at types of dementia. We have Alzheimer's dementia, which is again, we talked about problems that with dementia where they are basically in cognition and in memory, thinking and memory, and global intellectual impairment. They really can't focus on things, and you'll see the agnosia, aphasia, agraphia, which is difficulty expressing themselves in writing, aphasia, and then we have the short-term memory loss, and then progressing to short and long-term memory loss. And Alzheimer's is usually caused by plaque formations in the brain, and these plaques decrease the brain's ability to process, and also in most dementias, it's felt that acetylcholine helps with awareness and memory, and so we have a decreased production of acetylcholine in the brain, which leads to, of course, the dementia. Wernicke's-Korsakoff syndrome, you'll see a problem basically only in cognition, and that person is not able to form new memories and retain facts, and they can have an unsteady gait. It is believed that vitamin B1, thiamine, really helps profoundly with this issue of a Wernicke's-Korsakoff. Okay, so that's the treatment for that, and they feel that it really helps. Vascular dementia, and it may or may not affect cognition, but it is secondary to strokes. So this individual's had many strokes, and eventually they wind up in a place of dementia. And you can see depression or pseudo-depression with the vascular dementia. We also can see Parkinson's disease causing dementia. Parkinson's, of course, has to do with decrease in dopamine. The nigra substantia, or the substantia nigra, doesn't produce as much dopamine as it used to, and dopamine, as you know, is necessary in muscle movement and also in brain function, orientation, in a sense, attention, and putting you on alert and awareness. So muscles can become slow and rigid, like we see in Parkinson's, and excuse me a minute. Okay, so we could see that with Parkinson's. We could also see dementia forming. Okay, the causes of Alzheimer's disease is believed that it's a genetic cause, a polypoprotein E gene on chromosome 19 is believed to be a cause. Inflammation, vascular disease, strokes also share a relationship with Alzheimer's disease. There's also free radicals, too many free radicals flying around, and you know that free radicals cause cancer. It's believed that there's a connection between oxygen free radicals and cancer. It's when an oxygen atom is split and an oxygen free radical flies off. Hormones and growth factors. Women taking estrogen and progesterone increase the risk of dementia. Vascular changes from the inflammation of vascular disease. For example, hypertension, smoking, and diabetes. And it is also believed that lifestyles and education, like regular exercise and cognitively stimulating activities like studying and reading, decrease Alzheimer's disease. Okay, so there are some good things to say about studying and reading and remaining educated. As I mentioned before, evidence shows that drugs that inhibit acetylcholine, okay, destruction, those you would inhibit inhibit acetylcholinesterase. Acetylcholinesterase is the one that breaks down acetylcholine. So you inhibit that one, and now you have more acetylcholine, and it can slow the deterioration of memory and function in mild to moderate AD. Once it moves from mild to moderate away from there, then there's no stopping it. Okay, evaluation of the plan of care for dementia. The client's physical needs are met. The client is well nourished and well hydrated. Okay, because remember, these patients have difficulty taking care of themselves, and you will have to feed them and make sure that they're drinking, make sure they're clean and bathed, and also that they don't sustain any injuries, because they can be usually they're impulsive, and or the judgment is off. Okay, and help them to avoid episodes of wandering or agitation. You have to manage that successfully also. And the patient should be satisfied with their quality of health and quality of life at that moment, and that support is in place. All kinds of support issues have to be dealt with. Okay, so thank you very much. That's it for cognitive disorders.